So cardiac arrest survival. Two things that will tell you if you're going to survive a cardiac arrest. The first one is your initial rhythm. We're looking for either VFib or VTAC. Those two rhythms have a higher survivability than PA and asystole. Then the other one is your zip code. High-performing EMS systems have a much higher survivability than your standard run-of-the-mill EMS system.
Sounds right.
Welcome to In Service, the EMS podcast, where frontline experience meets leadership insight. Hosted by Jason Falvey, a seasoned paramedic and EMS leader with over 30 years in the field. This show brings you conversations with people shaping emergency medical services today. From street-level medics to innovators on the bleeding edge of EMS, we dive into real stories, leadership strategies, and what it takes to build high-performing teams in high-stakes environments. Let's get in service.
We copy you down, Eagle.
Sam Oxford is a seasoned EMS leader who has spent more than a decade working where medicine, urgency, and decisive leadership collide. As a nationally registered paramedic and certified flight paramedic, Sam has built his career caring for patients in unpredictable, high-pressure environments where clear thinking, clinical judgment, and strong teamwork can make a life-changing difference. His experience spans frontline emergency response, critical care transport, flight, clinical operations, and the leadership of professionals entrusted with serving people on their most difficult days. That field-tested perspective gives Sam a grounded understanding of what excellent pre-hospital care requires. Not only medical expertise, but also preparation, adaptability, trust, communication, and the ability to remain composed when stakes are at their highest. Based in Georgia, Sam is passionate about strengthening people and EMS systems. He brings an honest, practical voice to the conversation about EMS leadership, workforce resilience, clinical readiness, decision-making under pressure, and the rapidly changing demands placed on today's paramedics. Let's get into it. All right. Welcome.
Thank you.
How you doing this morning?
Good. So far, so good.
Good. In today's episode, we're going to explore how paramedics can remain calm and make better decisions under pressure through stress inoculating, deliberate practice, honest post-call debriefing. We'll also examine the transition from ground EMS to flight medicine, the clinical logistical challenges of critical care transports, and why sound judgment must extend beyond simply following a protocol. Along the way, we'll discuss credible leadership, professional accountability, and the culture required to build high-performing EMS teams capable of improving patient outcomes.
Yeah.
So, Sam, where'd you grow up? Where are you from?
I'm from just south of Atlanta, in a town called Fayetteville. Grew up there. I found myself interested in EMS. My brother-in-law was a paramedic down there. So I did a ride-along while I was in high school, and I did one ride and fell in love with it. Like I was like, oh, this is what I'm meant to do. So
Yeah.
After that, I graduated high school, went to EMT school, and while I was there, I worked at a hospital. And then right after EMT school, I went to paramedic school, and then that's when I got my first job in an ambulance. So I didn't touch an ambulance until I was actually a paramedic. A little bit different than what people are doing nowadays.
We had a high school intern here a couple of years ago. He was here to review operational leadership type things, but he ended up going out to the scene of it was a shooting with a person held hostage, and he saw the SWAT team roll up, and the ambulances are coming in, and fire is all set up on the ground, and I'm like, he's ruined. Yeah. He's in it now. He's going to want to do this.
That's right.
Any calls in your career stand out to you?
Yeah, so I'll tell you, the only story that I tell is this story. I don't tell that many EMS stories. The one call that stands out in my mind that kind of set my career is young paramedic, so this was probably 15, 16 years ago, and we get dispatched out to a medical call, general medical, get there, fire department's on scene, and I see this woman standing outside her driveway. So I just grabbed the bag, walked down there, hey, how are you? She said, I just want to get checked out, I just don't feel good. I said, okay, yeah, come on to the truck, we'll check you out. So we walk up her driveway, and I noticed I didn't bring a stretcher or anything, right? Just brought my bag, right? So as we're walking up the driveway, I see her attitude starts to change, her mood starts to change. And then we get her into the back of the truck, and she's completely different. Like, she's struggling to breathe. Now she's diaphoretic. She's looking at me. She has these big eyes. You can always tell, you look at someone's eyes like, oh, this isn't good. And so I'm 21 years old, just got out of paramedic school probably 6 months ago. I'm like, I don't know what to do. So I put the pulse ox on her. Pulse ox is in the 70s. I can't get a blood pressure on her. I can't put her on oxygen. She keeps taking the mask off. I try for the CPAP, takes the mask off. I'm like, I don't know what to do, right? That's what I look at my partner. She looks at me and she's like, I don't know what to do either. I said, well, let's just go to the hospital. I remember this helpless feeling that I didn't know what to do for this patient. Up until that point, I was 6 months in to my paramedic career. I thought I could do no wrong. I had 1 or 2 ROSCs at that point. I was running all the trauma. And then this was the call that kind of knocked me on my butt. And I was like, oh, I don't know anything. Like, I know nothing. I don't know this. So we get her to the hospital. It turns out she has this flash pulmonary edema. Her blood pressure is super high. But I get in there, and they just hop into action and knew what to do. And I'm standing there, and I'm like, I didn't do anything for this woman. And so that was the turning point in my career where I realized that paramedic school only teaches you the minimum, just the bare basics so you don't screw up.
Right.
There's so much more to this career than paramedic school. You have to take that initiative on yourself to get good at your profession. That was the real turning point for me, that call. Every time I tell the story, somebody will come into my office and they'll say, hey, I think I screwed up. Hey, I screwed up too. Listen to this. So that's the story that I tell to help people and to show them that they're not alone. It's okay to make a mistake. Just don't make the same mistake twice. And that's kind of how I view things.
Yeah.
That was the turning point in my career. Luckily for me, it was only 6 months in, and then I realized there's so much more that I have to learn. There's so much I don't know.
Yeah. How many congestive heart failure patients have you seen at that point in time?
Yeah, not many. Right.
It can be difficult for that new provider to gauge how severe they are.
Yeah.
Outside of the vital signs, what the vital signs are showing.
Yeah.
Yeah.
Absolutely. And, and looking back on that call, because I look back on it probably once a week. I'll be driving home and I'll think about it and I'm like, all right. And it's really a gauge, like how far that I feel like I've come. And I look at the mistakes that I've made in the past, especially with patients, and I'm like, I can't believe I did that. But for this call, looking back, I didn't do an assessment, right? For that patient, I didn't assess her. I was like, hey, yeah, come on to the truck. We'll take a look at you. If I would have done a real assessment, I could have, before she flashed, I could have done something, right? Or could have led me to think something else was going on. If I'd have brought my equipment other than the bag, right? If I would have done vital signs and put the pulse ox on her, took my stethoscope and listened, right? I could have made a lot better of a judgment call than, hey, just come on to the truck. Let's take a look at you.
Right.
So,
if you've been in this career long enough, you realize that sometimes calls don't go well.
yeah.
Sometimes they just don't. But you can learn from every single call you run if you choose to and get better every time.
Yeah.
Yeah.
I think that's important. After every call, what I started doing with my partners would be, hey, let's talk about this call. How did that go? Is there anything that you think we could have done different? I think I should have done this instead of that. I think that's important. If you debrief, it doesn't have to be a formal debrief. You have to come in and talk to the supervisor. But if you and your partner just debrief and talk about what happened, that's how you get better. That's how you improve.
Yeah. So remaining calm under pressure, is it an instinct or a skill that you can develop?
So I think really remaining calm is a skill that you have to develop, right? And it's one of those that takes time. It's not easy, especially with the new paramedics now. You kind of see it from my experience. It takes about 6 months to a year, maybe a little bit longer, for them to get comfortable in their job, get really comfortable, no matter the volume, right? If you're running 10 or 15, 20 calls a shift, it still takes that amount of time to develop that skill, to get used to it, put your reps in, right? There's this whole thought about 10,000 hours, right? That 10,000 hour mentality. And 10,000 hours is a long time. So what we've tried to do in my shop is we're trying this thing called stress inoculation. It's something I've kind of learned from the aviation industry in my transition back over here to ground. It's setting up a scenario and causing stress, more stress than what they're used to, different types of stress, get them used to that stress. What we found is after 2 or 3, if they come through 2 or 3 of these scenarios, on that third or fourth one, they really kind of rock it. You can tell that difference, like, okay, nothing in here is going to hurt me, right? Get them used to their blood pressure getting up, their heart racing. That's what our goal is when we set up these scenarios. Cause as much stress as we can in a controlled environment. That way, when they're in an uncontrolled environment, they're used to it by then. So
right.
That's what we've been trying.
I worked for another service a bunch of years ago, and our medical director was the director of the ER. And the hospital had just bought this mannequin, probably spent $100,000 on it. You could push medications on it, and it was special syringes, but it could gauge how much volume you push through that vein. And he could run these scenarios. And I remember he was introducing this mannequin to a group of our paramedics, and I happened to be there. And of all the people he pulls out, it's me. Jason, let's run through this scenario. At that point, I was more in a leadership role. I wasn't really in the field, and he's running me through this SVT scenario. That was so damn stressful.
Yeah, I'm stressed.
Especially, you can talk your way through a scenario like that. But when you're physically pushing medications and the mannequin knows what you just pushed and how much you pushed, it definitely takes it up a notch. He finally let me out, though. Went easy on me at the end, but yeah, definitely. And I guess that's stress inoculating, right?
Yeah, that's a little bit of it. And what we found, what I've done is you don't have to have these $50,000, $100,000 simulation labs, right? What EMS agency has $100,000 laying around to throw in a simulation room with those high fidelity mannequins? So we have a product. It's called the Reality Eye Simulate. And with that monitor, well, basically what it is it's a monitor, and it can be whatever monitor your service uses. If you use LifePak 15s, it can be a 15. If you use 35s, it'll be a 35. If you use a Zoll product, it'll be a Zoll product. It can be whatever you want it to be. It's basically an iPad, and it looks like it's in a case. And you have another iPad that controls it. So you control the heart rate, the vital signs, blood pressure, all that stuff. You can control the monitor with the other iPad. And so now we can do a scenario anywhere. Right, we can do it in the back of a truck when you're about to come on shift, right? Hey, let's run in here. Let's run a quick scenario. It'll take 5 minutes. Let's run a quick cardiac arrest. Hey, show me about your compressions. And now with that tool, they're not cheap, right? It's $10,000, but it's not $100,000 in a dedicated room. I can run a scenario anywhere. I can go to the fire department. We can run scenarios together between EMS and fire.
Right.
And so that's what we've started doing. Grabbing folks, taking them to the back of the truck before they hop in service.
Just what you want to do.
Yeah. That's what I want to do. But and then it's kind of eye opening too to them. They're like, oh, they kind of see the realization that I had during my call. Like, oh, maybe I don't know everything, right? And that's really what we're looking for is not only that stress, but for me, what I'm looking for is knowledge gaps. What do I need to focus my time on? So right now, I'm a clinical educator for a company here in Metro Atlanta, see where the knowledge gaps are and what do I need to focus on. So I'll run through a few scenarios, take some notes, like, okay, in a cardiac arrest, our pulse checks are 45 seconds or 30 seconds, whatever it is, way more than 10 seconds. I'll make notes, okay, this is what I need to focus on my next training. And also it's providing them confidence because over time you see it builds their confidence after you do this a few times, and that's cool to see. So the first couple times when you do it, they kind of roll their eyes at you. Great, here we go. Sam's going to come down on me.
What do you think the biggest thing a paramedic can do to reduce the cognitive overload they might be experiencing on a call?
Yeah, I would say
advance.
I think it's getting comfortable, knowing where your equipment is, being able to work well with not only your partner, but with random people you've never seen before, right? You may not know that engine 99, right? You may not know that crew, but they may show up on your scene, so you need to know how to direct a scene, right?
Right.
And that's another skill that comes over time.
It's interesting because I often tell our EMTs here that when they're checking their vehicles out, make sure you know where certain equipment is. If the medic is asking you for a CPAP, you should know where to get that from. Yeah. You don't want to be searching around for a minute and a half while they're trying to put together a treatment program for this patient.
Yep.
Yeah.
Or something as simple as a glucometer. Right? Did you look at the glucometer that morning? And then 6 hours later, you don't know where it is.
Yeah.
Yeah.
Where are there any, I don't want to say shortcomings, but with that simulation model, where do you think there are shortcomings in it?
I think the biggest shortcomings are sometimes the scenarios can be unrealistic, right? No matter how high fidelity your mannequin is or high fidelity your monitor is, it's still not a real patient, right? In the back of your mind, if you're going through a scenario, no matter what you do, you're not going to kill anybody, right? You're never going to cause harm to this piece of plastic. So I think that's the biggest shortcoming is it's still not real at the end of the day. What we want to do is just increase the stress and get your hands and your mind working together, right? And that's what we're looking for, is just you getting used to that stress, a high stress environment.
Let's talk about transitioning from ground to air operation. What changes when patient care moves from a ground ambulance into a flight environment?
So I'll give you my hot take. Not much.
Still a patient.
That's right, still a patient. So for me, flying was always a goal. Ever since I was working in the hospital, I remember the first time we had called a helicopter to come fly a patient out, I was like, that's what I want to do. I just didn't know how to do it. So after I started my paramedic career, that was my goal. And I was like, all right, I got to build my resume. So I worked for a busy service here in Metro Atlanta, moved on up through the ranks. I was an FTO, became a supervisor, scored my first interview, got denied. I'm like, okay, great. I guess they don't like me. Then scored my next interview. They said no to me again. I'm like, what? What is going on? Then I started talking to flight crews, going to they put on a lot of education, so I'll go to their education, speak to them there. Really what it is, they're not looking for how smart you are or how good you are. They're looking for how are you going to be able to work as a member in this high-performing team, right? That's what they look for. Their mindset is they can pretty much teach anybody anything, right? I can teach an EMT right now to intubate, right? I can teach them that. It's how are you going to perform under stress and how are you going to work well in a team,
Right.
That's what they look for. Once I learned this, I was like, oh, I'm answering the questions wrong. These interview questions like I'm a supervisor. I need to answer them like I'm a part of a team. That was the big change for me. Getting to know the flight crews, letting them get to know me, know my name, figuring out that, hey, I'm a member of a team here. I need to start acting like it. And that's what changed for me, and that's what got my foot in the door in aviation. I flew here in Georgia for 5 years, and the biggest difference between the patients that we took by ground and took by air, there's no difference. It's the same patients. In my mind, I thought, I'm just taking care of sick people all the time. It's going to be sick and trauma. No, it's the same patients. We still ran the same patients, and that's the same thing. The biggest difference between ground medicine and flight medicine, at least here in our area, is in the flight world, they treat you like a professional, but they also expect you to act as a professional. One of the biggest struggles that I see people is time and attendance, right? Showing up to work on time. There's not an option, right? And the team will check you too. They'll say, if I'm late for a shift, the expectation is that I'm there 30 minutes early in case they catch a flight. Because once you catch a flight, you're gone for 2.5, 3 hours.
Right.
And so the expectation is, hey, you need to be there 30 minutes early. That's the team expectation. It's not a company expectation. That's the team has expectations. You need to be there early. You need to make sure that you are doing your education on time, right? And not having the manager call you and email you and tell you need to get it done. You should do everything that's expected of you without them even asking. That's the biggest difference is they treat you like a professional, but they also want you to act like a professional, like this is your trade, right? That's the biggest difference between the aviation world and ground EMS. Other than that, it's the education, right? When I was on a ground truck, I was like, man, I don't get any education, nothing at all. And then I went to the aviation side. It's shoved down your throat. You get you get all the education you've ever wanted, and it's going to be done, right? And that was the great thing for me. It made me a better clinician, way better. Those are the two biggest differences: is the education and the professional side. Like they want you to be a professional, and they treat you like a professional.
Right.
There's not a lot of babysitting. Everything's
You have a massive responsibility.
I think it's all the same. We're still treating patients, right?
True. But you got the complication of flight, right? And there's a lot that goes with that.
Yeah. And luckily, where I used to work, we had a great set of pilots. Especially me coming in, I was like 30-something when I started, probably 30. Coming in, knowing nothing about aviation, and they kind of took me under their wing and taught me everything about weather patterns, flight physiology, and all these other things. I'm super grateful for all the pilots and flight nurses and flight medics that I worked with. It's a very mentoring community. They want to build everybody up together.
Right.
It's great.
That's awesome. Is there more to the hiring process that somebody interested in flight should be aware of?
Yeah. So I think the first thing if this is something you're interested in, you're not scared of heights, is really building your resume as best you can. So work on building your resume. Take all the classes that you can, all your alphabet soup classes, PHTLS, your BLS, ACLS.
More credentials, the better.
Yeah, the more the better, right? If you can, go ahead and get your FPC or CCPC. So that's your flight paramedic certification or your critical care certification. Go ahead and take that. It's not required, but it just makes you look better, right? That's one less thing they have to worry about. So work on getting those. We talked a little bit about stress inoculation. You may want to do a stress inoculation interview, right? So if you're anxious, sit down with someone and have them run you through questions. ChatGPT is a good source to pull up lots of these questions. Type in flight interview into ChatGPT and have them come up with a whole bunch of questions. Have somebody ask you those questions. Be prepared. They only got one chance to look at you, and that's it. The way the interview works is it's like a panel interview. 3 or 4 people will ask you all the basic questions. Tell me a time when, all those type of questions.
Right.
And then there's the clinical component, and they'll ask you 3 or 4 scenario questions. So if you're not good at tabletops, running through a scenario on a piece of paper, get used to that. Have somebody run you through those, like your STEMIs, your strokes. Know what to do in sepsis. Be comfortable with pediatrics.
There aren't many people comfortable with pediatrics.
Be as comfortable as you can, right?
Yeah.
Just get as comfortable as you can. And if you don't know something, before I started flying, I had never touched a ventilator, right? So they asked me a ventilator question in one of my tabletop scenarios, and I just told them I've never touched one. I'm not familiar with it, but it's something I'm willing to learn. So just because you're not familiar with something doesn't mean that you can't go through with the question. Just let them know, be honest and upfront. They're not looking for your skills as of right now. They're looking for what they can turn you into. So it's okay if you're not comfortable with, like in Georgia, RSI, right? So paramedics in Georgia can't RSI. So that's something I had never done, but it's something that can be taught, right? So they can teach you a ventilator, they can teach you RSI, they can teach you how to put chest tubes in, right? So it's just be comfortable, and also be comfortable with saying that you don't know.
Don't wing it.
Yeah, don't wing it.
Do some prep ahead of time.
Because if you do wing it, they're going to ask you questions, right? They're going to ask you questions, so be honest and upfront. And just remember that's what they're looking for, how good of a clinician they can turn you into, not where you're at right now.
Right.
So.
Let's talk about scene emergencies or scene calls versus facility transports.
Yeah.
What's the major difference there? How do you process that, or what are the challenges you see with each one?
Yeah. So each one has its own, they're almost 2 separate things. So where I was at, our bread and butter was STEMIs and strokes, whether at the hospital or a scene call.
Would these be rural counties?
Rural up in North Georgia. The biggest difference between the two is if they're coming out of the hospital, you have a lot more information versus a scene call where you're just presented with what you see. Coming from a hospital, you have labs, you have x-rays, you have CT scans, you have a lot more information that you have to be able to process and then make your adjustments.
And you're getting a more detailed report.
A much more detailed report, most of the time, right? But it's taking all that information from the hospital and processing it, kind of diluting it down and, okay, what do I need out of all this information, right? 100 different labs, CT reports, and x-ray. What do I need from that, and how is that going to drive my care, right? And so that's the challenge of IFT. I like the IFT calls because you got to do stuff I had never done before, right? That's where I became pretty proficient with a ventilator. I was able to look at a blood gas and then make my adjustments on my ventilator, right? Which versus a scene call, you're just kind of, you're not guessing, but you're kind of just putting them on like a standard thing.
Yeah,
so there you can.
Yeah, I agree with you. But I always found those critical IFT transfers to be much more challenging to manage.
A lot more challenging.
Especially if the transport duration was long versus a scene call. I'm just talking about ground operations. Yeah. You run through your protocol. It's pretty much laid out for you. And at some point, you're going to end up at the hospital, and it's usually pretty close.
Yeah, it's a lot more critical thinking. You know, it's like on a blood gas, right? And then making your ventilator adjustments. Or, hey, they're on 9 different drips. We only have 6 pump channels. How are we going to do this? All right, we can take that fentanyl down, and we can just push the fentanyl if we need to. Same with the Versed. Okay, their blood pressure is on this. I wonder if we can take them off this other pressor, right? And so you have to think about how you're going to move the patient and the logistics of moving all that.
Right.
So you're moving 6 drips, right? Making sure you don't pull something out with a ventilator. Sometimes they're on a balloon pump or an Impella. And that's a whole different world. It's the logistics of moving a patient, especially those super sick IFT calls. That was a challenge. But my favorite part in EMS is being able to walk into a chaotic scene, whether it's in the hospital. Sometimes you walk into the ER and it's, hey, thank God you're here. This is what we got. And then you're like, oh no, I'm this
The
mess.
hot potato scenario, right?
But that's my EMS high, right? I walk into a scene and bring this calmness to a scene, whether it's IFT or 911. I love bringing calm to a scene. But in order to do that, you got to put your reps in too, right? You have to be confident. You have to know your stuff too. Yeah, those are the biggest differences between the IFT calls and the 911 calls. Is IFT, there's a lot more critical thinking. Growing up in EMS, nobody likes the IFT world. But when you bring that critical thinking element to it and then like, hey, I can actually do something, that's the big change, aviation versus ground, in my experience.
What brought you back to the ground world?
Well, I left ground in 2018. And every time I've left a job, it's because I've completed my goals. Like I set out these goals that I want to complete. And with flying, my goals were to be confident and be able to take care of sick people, right? That was my goal. Like knowing if somebody is critically ill, I know that I have the capacity to take care of them. After flying for 5 years, I felt like I've completed everything. I ran the STEMIs and the strokes and did chest tubes and RSI. We did all the things, and I'm like, I think I need a new set of goals. I need something else to accomplish. And for me, in my mind, I was like, I wonder if I can bring this professionalism side, this education side to ground. And that's what my goal is now, is to bring all of that to the ground side.
And you're an educator too, so I'm sure there's a pull there.
I never thought I would be an educator, but it's something I kind of fell into, and I really enjoy it. I enjoy trying to bring that aspect of it, bringing the stress in, bringing critical thinking, thinking outside the box for some of these calls. I enjoy bringing that into the ground world.
I never thought I'd be a podcaster. But here I am. You know, you've been in different leadership roles over the years. And what does credible leadership look like to the professional on the road? That's a tough one.
That's a tough one.
Yeah.
I think it's somebody that you can go to, but it's also somebody that's going to hold you accountable. If it's somebody that I can go to with an issue, they're going to help me resolve a problem. But if I screw up or I do something, they're also going to hold me accountable. And that's what I have tried to do is...
And accountability doesn't mean you're going to burn that person to the ground.
But if I'm doing something, if I'm consistently late, it's the most common thing, or something, they're going to let me know, hey, I'm watching. What is something that I can do to help you? Do I need to call you an hour before your shift to help you come in? What can I do to help you succeed? And I think that's what credible leadership looks like today, is having leaders that care and show that they care to the employees, right? And also build them up. I think we're kind of in this world where we've forgotten what leadership is. Remember, we're trying to build this career and build these EMTs and build these paramedics. And a lot of times we just kind of write them off, and we're not doing a lot of building. We're doing a lot of writing them off. Hey, if you didn't make the cut by, it's like, well, no, let's try to build them.
Right.
And that's what I try to do.
What's interesting, you were saying earlier about the interview process for becoming a flight paramedic. Even the interview process for moving into a leadership role, something that's very uninspiring is when somebody sits there and says, well, I'm kind of done with the truck. I want to get off the road. That's not telling me why you want to lead people. Yeah, it's kind of one of those things that sneaks up on people.
Yeah, I don't like.
Don't say that in an interview.
Yeah, don't say that in an interview. Yeah, I'm never done with the truck. I love the ambulance. When I came back to ground, I was on the truck for 6 months before this position opened up. I had an idea that this position was going to open up, but I had no issues coming back and getting on a truck, and I loved it. I loved every minute of it. Now, my partner didn't, because we were turning and burning calls. Like we were working those 12 hours, but I enjoy it so much. I love walking into somebody's house and say, hey, I'm Sam. What's going on today? Because I know that patient's going to get the best care. If I'm there, I know that patient's going to get the best care that I can give them. I love talking to patients, even like the nursing home calls. You may be the only friendly face that patient sees, right? Because they're used to in their semi-private room, the person in the bed next to them, the nurse
The
coming in and
caregiver,
out. That gets so mundane after a time. To see a fresh, smiling face walk into the room, hey, how are you? Well, what's going on? Do you want to go to the hospital? It kind of like, yeah, actually, I do. Get me out of here. I enjoy trying to make an impact on people's lives, just something as simple as a smile and, hey, what can I do? What can I do to help you?
I did a podcast episode out in South Carolina. The medic was telling me a story about how he worked in Boston for a period of time. He was telling me a story about doing this interfacility transport. He did not find that challenging. But the guy he was transferring was a medic during the Normandy invasion. He was one of the first boats on the beach.
That's cool.
It was halfway through the trip before I even got into that with him.
Yeah.
You think about that, right?
That person, they were probably really cool about 30 or 40 years ago, right? I mean, they were probably, you never know what their story is. And then they start talking, and it's like, oh, wow. Like, you've seen some stuff.
And we talked about that call after the episode, but I'm like, very few people have tried to kill me during the course of my career. Very few. Half the people on that beach were trying to kill that guy while he's treating patients, his friends.
That's crazy. I couldn't imagine.
Brings a whole different perspective to what we do.
It does. Yeah. So you never know who you're talking to, right? You never know what their life was. At the end of the day, what I tell everyone, no matter what, if you're a good clinician, bad clinician, whatever, just be nice. Kindness is the number one thing that'll keep you out of trouble.
Right.
And then the second thing, it's going to keep you under the radar because nobody's going to complain about somebody that was super, super nice to them. So that's my number one rule. Just be nice. Seriously. It'll keep you, and there's actually some data behind it. It'll keep you out of litigation as well. Like, people don't want to sue somebody who was very nice to them. It's difficult for me to sue you if Jason's a nice guy. It's difficult for me to be like, yeah, I want to sue him because he, whatever. It'll keep you out of a lot of
Cause
trouble.
phlebotomy.
Yeah, exactly.
Yeah.
Yeah. Just be nice. That's my number one takeaway. Be overly nice to everyone that you meet. Hospital staff or patients or family members. Just be nice.
You had talked earlier about in flight, how the team would hold you accountable.
Yeah.
And that's really, when you're talking leadership, that's really a byproduct of the culture of that group of people.
Yeah.
But that's kind of always the thing that attracted me to leadership roles was building that high-performing team, right? Developing a culture where the individual providers will start raising the standard amongst themselves. Mm-hmm. And I think that's really hard to achieve.
Yeah.
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 But when you got it, it's something special.
Yeah. And we had a really good group. So in the aviation world, there's this thing called GAMUT, G-A-M-U-T. Basically what GAMUT is, it takes all of the data as part of the accreditation, the CAMES accreditation. Basically what it does is it takes all of the data, so like a first pass success for intubation, for example. It'll not only take it from your service, but from every flight service in the region. Whether it's your company, another company, it takes all of them, and it kind of scores them. Our group of clinicians were like, hey, we're going to do this. First pass success intubation. We're going to shoot for 100%, right, which is super challenging. It's hard for physicians to do 100% first pass success in a quarter, much less a bunch of nurses and medics, right? So, and that's the thing, that's what really drove us, is we wanted to do well. We really wanted to do well. That's just so different than the feeling I got on the ground side.
Do you think that's the difference, what you just said, about a group of capable clinicians versus a really high-functioning, high-performing EMS team?
I think part of it is everybody had worked so hard to get there. Me as a paramedic right now, I can walk in anywhere in Metro Atlanta and pretty much get a job. As long as I'm nice, right? I can walk in there and get a job. There, everybody worked so hard for years. So you had to have 3 years of experience, both nurses and medics. We all went through this stringent hiring process. So you had to do this tough interview, tough clinical scenarios, the third ride process. So you had to third ride, I think it was like 10 rides. It may have changed now, but you had to do 10 rides. You had to hit different goals, like they wanted you to do an intubation. And then at the end of all that, they run you through 4 high-fidelity, clinically challenging scenarios where it's just you, an evaluator, and that's it, right? And the only thing you had was your protocols. And everything's on a time, right? So you have 10 minutes to run each scenario. And so you would walk in with a super sick patient in this high-fidelity sim lab, and you had to figure it out yourself, right? And that was super stressful. But with that stress, you get used to stress, right? You do that once or twice because then you had to do it annually. So after your new hire process, you do it, and then it's annually every year. So then you get used to it. You're like, oh, yeah, I got to go to the sim lab this year. But that first one, I remember thinking, I'm not going to make it through this. It's terrible. I don't know half these drugs. What am I going to do? But you get through it, and then it's like, oh, I can't.
God, that's got to be stressful.
It's so bad. It's so bad. And then at the time, it's changed now. At the time, it was punitive. So if you failed when you were taken off of flight status, you couldn't fly again until you had redone it. So they've
the
changed
stakes
it now.
are high.
Yeah, the stakes are high. But it builds your confidence because it's like, yes, this is hard, this is challenging, but I can do it. If I can do it here in front of this lady with a clipboard, then I can do it for real out there. And so it builds your confidence, you get used to it. And that's kind of what I've brought to the ground side where I'm at now in my shop, is taking a little bit of, not as intense, we're not going to take you off of ground status, but yeah, it's just showing you what we can work on.
Right.
Yeah.
So you were talking a minute ago about what makes a flight crew such a high-performing crew. You've all gone through the same interview process, credentialing process. You do the stress inoculating in the labs. We are all running these very difficult calls. And so you can trust the person next to you that they're at your level. I think mutual trust is a big component of high-performing teams. Trust doesn't mean you're going to turn a blind eye to something that doesn't go well.
Right.
I think it almost requires you to hold that person accountable. And that doesn't mean destroying them. What are your thoughts on that?
That's where every call, and this was almost company-wide. I could pick up a shift out in Arizona, and then the same thing would happen. After the call, we would be flying back to the base, and it'd be me or the nurse or the pilot. It would ask, hey, how did everything go on that? We would always just do a mini debrief. No matter who I was working with, it could have been the first time I was working with that person, we would always just do a debrief and talk about it. Hey, what'd you think about this? Do you think we should have done this? That's where that's what me and my partner used to do on the truck. I didn't know it was a debrief. We were just talking through the call. That's one of the big differences between ground and aviation. Everybody just wanted to get better. We wouldn't call each other out. The nurse wanted to go down a different pathway than what I wanted to go down. Afterward, we'd talk about it. Why were you thinking this? Why did you want to do that? Explain it. I missed something?
Like a medication choice?
Medication choice. It could be anything. Why did you want to do this? Why did you ask me to make the adjustment on the ventilator? Why did you want to increase the flow rate of whatever medication? And we would just talk about it. When I kind of found out is that open communication, even after the call, that's a trust-building thing in and of itself, because then it's like, oh, you're not going to run and tell somebody that, oh, Sam's terrible because of this. Oh, if I screw up or if there's a question, they're going to come to me. Right? They're going to ask me about it, and then we can have a discussion. We can sit there and we can talk about it, and I think that builds a lot of trust. It was interesting because any clinician that I worked with, we all did that, and it was like this inherent thing that everyone did.
And there's a difference, right? If you have a difference of opinion on a course of treatment that maybe your experience level is guiding that difference of opinion versus you flat out chose the wrong medication.
Right, yeah.
You thought this person was in SVT, but really it's something completely different.
Right.
Hey, it's Jason Falvey. Thank you for spending part of your day with me. If something in this episode hit home, maybe it reminded you of a call, a difficult shift, or a lesson learned the hard way, visit us at inserviceemspodcast.com. You'll find more episodes, articles, and resources created for EMS professionals. While you're there, subscribe to the newsletter. And don't forget to follow the show on your favorite podcast platform. Now, let's get in service.
Yeah, but I always enjoyed those conversations because I'm not perfect. It's nice to have somebody ask you questions. And then you're kind of thinking, oh, shoot, well, maybe did I miss something? And it kind of gets you thinking. And I think that's the biggest thing that kind of builds trust within those crews is everybody's super open about communication. The pilot's open about his weather decisions and whether they're going to take off. And, hey, we can't do this. Hey, if we take this flight, we can't go down to Atlanta, but we can get up to Chattanooga, right? Everybody is open about everything, especially clinically. Pilots were open about the decisions and how they came to that decision. They would show you on the map. So they would show, hey, there's a storm cell over here. So if we take this flight, we're going to have to go to we can either go here or here.
Right.
And we all came together to make decisions together. And it was a great experience.
Do you ever have any close calls?
I don't think we did. There was times we got stuck. So we would get stuck. I remember getting stuck in South Carolina, Greenville or something. And then it was like a 2.5 hour drive back. We had to go rent a car. And then it was this big thing and then leave the helicopter there. And of course, it's 3 a.m. and everybody's tired. But I personally never had any close calls. People at my base in the same helicopter had. They had bird strikes, things of that nature. That's probably one of the scariest things that could happen because you just don't know. You're just flying along and all of a sudden, here comes a bird through the windscreen. But in aviation, they're making adjustments too, right? So they have bird-resistant windscreens now that they're putting in helicopters. They have fire-resistant fuel cells that are putting in helicopters. And the air ambulance companies, for example, crash-resistant fuel cells. It costs them a lot of money, and it adds weight to the aircraft, about 75 pounds. So it's decreasing their capability, but increasing safety. And so it's nice to see the aviation companies coming around and adding these safety features, even if at the expense of a little bit of capability. So it's not the aviation, especially the air ambulance industry, is coming around to all these things and adding safety features and updating fleets.
Right.
So it's nice to see.
You talked about openly communicating with your crew.
Mm-hmm.
Let's talk about closed-loop communications.
Yeah.
How much of a role does that play, and what's the benefit of that?
The biggest benefit is you know where everybody's at, right? For example, let's say a nurse and I are doing an RSI in the back of an ambulance. We've made the joint decision that we're going to RSI this patient. Then I know exactly what she's doing, and she knows exactly what I'm doing. She'll say, I have the rocuronium and ketamine pulled up. Let me know when you're ready. Okay, I am ready. And she'll say, hey, all right, I'm pushing the ketamine. Ketamine's in. That means I know exactly what she's doing. I know exactly where she's at.
Right.
And then she'll push the rocuronium, right? And I'll say, okay, I'm going to go ahead and intubate. We have a checklist. Aviation's big in a checklist, and it's coming over to medicine. And so we'll run down the checklist, and I say, okay, I'm going to go ahead and intubate. Okay, tube's in. Can you do this? Can you hand me the capnography? So I'll put the capnography at the end of the tube. And so everybody knows where everybody's at, right? It's not in limbo. I know exactly what she's doing.
It adds to pacing, right? If she's announcing when she's pushing a certain medication, you know
right
exactly when you're going to need to move.
Yeah.
Insert your laryngoscope.
Yeah.
Yeah.
And then you get, once you've worked with somebody for so long, it just becomes like a choreography. It just kind of runs. I've always said, me and my flight nurse partner, Jamie, we didn't even really have to talk. We knew exactly what we were doing each time. It got down to just like a look, right? She would just nod her head. I knew exactly what was going on. It's crazy what two people can do. I've always said that her and I could do what it takes a team of, like an ER team and a trauma bay to do. We could just flow through it because that's what we did, right? We trained. It goes back to training. Trained every day, right?
Yeah.
With the mannequin out to the helicopter. We'd practice intubations and weird scenarios. So her and I, and really any clinician, the two of us could get done what it would take a trauma team to do at the hospital, with just the two of us.
It really is a special thing when you achieve that level of chemistry, synchronicity.
Yeah.
It really is a unique thing.
Yeah, and it's funny. Her husband and us went out together not too long ago, and we were sitting. She's a nurse practitioner now, and I'm here doing my thing. And we were sitting there at dinner, and we're like, we did some really cool stuff. I was like, yeah, we did some cool stuff. It's just nice to sit there and reminisce, and
yeah.
So
let's talk about clinical judgment beyond the protocol.
Yeah.
What should a paramedic do when the patient doesn't really fit within an established protocol?
Yeah.
And so many of these patients hit that category.
Yeah.
They're straddling protocols. these complex patients.
That's challenging. The best thing you can do is do a good assessment. Back to the basics. Do the best assessment that you can. Put your hands on the patient. Have you felt their abdomen? Did you listen to breath sounds? Do a good assessment. Take good quality vital signs. If it looks weird, if the blood pressure looks weird, check it again manually. I think that's where a lot of paramedics kind of fall in. Well, this patient had this and it didn't make sense with this. Let's go back to your assessment. Let's make sure we're doing a good quality assessment on those patients. And then let's say the patient doesn't fit something. That's where critical thinking kind of comes into play. I'll give you an example. Let's say you have a ROSC patient, right? You work cardiac arrest, you get a pulse back. During that cardiac arrest, let's say you have put in an ET tube, right? You've intubated the patient during the cardiac arrest, and now post-arrest, you got ROSC, they have a pulse, and now the patient's starting to wake up, right?
Right.
So the way that...
Which is good.
Which is a good thing, right? It's a good sign. But we don't want them pulling their airway out, right?
Right.
In my shop, we don't have a post-intubation sedation protocol. We have we have a sedation protocol for the agitated patient, and then we have a pain protocol. So that patient doesn't necessarily fit into that category, right? It's kind of between categories. But what we can do is, one, is that patient in pain? Probably, right? They just had chest compressions done for 10 minutes. They probably got a couple broken ribs. They have a piece of plastic the size of their finger shoved down their throat, right? So they're probably in pain. So let's give them something for pain. And then are they agitated? Are they going to cause harm to themselves? They could, right? They could pull their IVs out.
They could pull that tube out.
They could try to pull that tube out. It's about making the guidelines fit your patient. Think outside the box. So that patient, we can give them some pain medicine because they're probably in pain. And then let's give them something for their agitation. Just because that patient didn't fit that box of post-intubation sedation, because that's what I'm doing, but they fit 2 other boxes. So It's about making the patient fit to where it's going to make sense to somebody else. And you have to do what's best for the patient. What's best for the patient right now? And so that's how I navigate those things.
Do you think that's a protocol limitation?
Probably for us.
Because now you're relying on that clinician to apply more critical thinking skills, right? Adaptive thinking skills.
Yeah, and that's why you see...
And that scenario you just gave is perfect.
It's something we've run into. And it's like, okay, we need to go back and look at our protocols. Maybe this is something we do need to add. But also, especially with our medical directors, they have named our protocols guidelines for a reason. Because they know that not every patient is going to fit a protocol, right? You're going to have some weird patient that's not going to fit something. But if they're guidelines because they're supposed to guide you kind of in the right direction. And it's okay to be flexible on them, because we know that not every patient is going to fit a guideline or fit a protocol. It's about how can you as a clinician critically think through this and do what's best for the patient, and here are the tools.
And be able to articulate your thought process afterwards.
And how do you do that?
Yeah, because if you just jack that person up with ketamine,
The
K-hole,
right,
and you can't explain why you did it.
Yeah, just don't put them prone. So you have to explain it, and that's where good documentation comes into play too, right? Documentation is what's going to save you 100% of the time. Right. We do a good job at putting the big picture stuff in there, but we don't do a good job of putting the more nitpicky little things in there, right? Like, hey, I placed an IV. Where did you place the IV? That's important, right? Where did you place that IV? That's important, right? We need to know where that IV was placed. If you gave an injection, where did you give the injection? Did you give it in the left deltoid, right deltoid?
All right, so you're saying documentation.
Good documentation is important, and that's what's going to protect you. Not only from litigation, some sort of lawsuit, but even just the hospital has a question. Right? Hey, did you give aspirin? Oh, shoot, I forgot to give aspirin to the STEMI patient. I didn't document it. Or I gave aspirin and I didn't document it, right? So then the hospital has questions about those things. So good documentation is important. Not only to protect you from litigation, but it's good for the continuity of care.
Right. I think that the ROS call you just described would be a wild scenario to run on somebody for a stress inoculation.
Yeah. So it's funny, the last
Do you
scenario,
use it? Yeah.
No, I haven't used that one, but it's in the works. So the last scenario I ran was a trauma call. We have a patient that fell off a roof. You get there, a little confused, nothing obvious, put it in the back of your stretcher. You notice that the patient has a seizure, right? And then if you don't look at the monitor, you're going to go down the wrong pathway. If you look at the monitor, you're going to notice he went into VFib. If you don't look at the monitor and you just start giving him some Versed, you're going to go down completely the wrong pathway. You're going to notice he had a seizure because he went into a VFib arrest, and then you have to kind of go down that. That's one of those things that's hard because you don't have the patient in front of you. You don't have a mannequin that can go unresponsive. Have a seizure, then go unresponsive and not have a pulse. You have to kind of work through it.
You know, that scenario you just described, we had a very similar. That patient you just described, we had a very similar call just a few weeks back.
Yeah.
Yeah.
That's crazy.
Yep.
Yeah. But yeah, that was the scenario, right? You do that, and then, if you do the cardiac arrest appropriately, treat it appropriately, you'll get ROSC and then kind of treat the patient.
Yeah.
But yeah.
Let's talk about CPR.
Yeah.
Right?
Let's do it.
I know you've been.
That's my passion, PR.
Yeah.
So what do you want to know about cardiac arrest?
So why do cardiac arrest survival rates vary?
So cardiac arrest survival, two things that will tell you if you're going to survive a cardiac arrest. The first one is your initial rhythm. We're looking for either VFib or VTAC. Those two rhythms have a higher survivability than PA and asystole. And then the other one is your zip code. Your zip code can tell you your survival if you have a cardiac arrest right now. Part of it is demographics, but the other part is a high-performing EMS system. High-performing EMS systems have a much higher survivability than your standard EMS system. A lot of this data comes out of Seattle. They have there's an organization called the Resuscitation Academy. They've done a lot of research and training, and what they found is if you focus on the two things that matter in cardiac arrest, electricity, right? So shocking somebody that's in VFib or VTAC, and high-quality compressions, consistent compressions, then your survivability can be 50, 60, 70%. Some of these areas are seeing as high as 65, 70% out-of-hospital survival if your initial rhythm is VFib or VTAC.
Wow.
In the state of Georgia, you're at 14%. So it's a big difference, right?
Yeah.
And some of these areas are pretty rural where they're getting 60% survivability with VFib or VTAC as the first rhythm. They're doing it because they have the sheriff's office or they have PD that's participating. They have volunteer firefighters that are participating that are all highly trained in just compressions, right? The most simple thing that we do, right? This is what we learn on day one of EMT school, right? You get your CPR card, is getting good at compressions and getting good at cardiac arrests. Cardiac arrest is something that EMS, EMTs and paramedics, EMS in general, that's what we do, right? That's what we do is cardiac arrest. And so what they found is really the only two things that matter in cardiac arrest are electricity and compressions.
Right.
And the Resuscitation Academy has kind of developed a system to where you reduce pauses in compressions, less than 10-second pauses. Realistically, it should be less than 4 seconds. You can get it down to less than 4 seconds.
Now, is the standard still a 10-second and more interruption in CPR requires 2 minutes of compressions to,
Yeah, compressions above all else, right?
Yeah.
And even if you do a shock, right? Let's say we have somebody in VFib and we're going to deliver a defibrillation. So if you just make a couple of adjustments, you can really get those times down. So what we started doing and what we're working on doing, this is a process. It's not going to happen overnight. It's a slow burn.
You're trying to change the cultural mindset.
And then change the cultural mindset of Lucas. I'll tell you about Lucas in a minute.
I actually just wrote down Lucas because I'm going to segue into that.
Yeah, I got a love-hate relationship. And so one of the ways that we found to minimize pauses are what the Resuscitation Academy teaches to minimize pauses. There's two big things you can do. Pre-charging the monitor. So as you're doing compressions, charge your Zoll or charge your life pack. It doesn't matter what rhythm they were before. We're just going to go ahead and charge it while we're doing compressions. And then we're going to get our hand placement. So we're going to go ahead and feel for a pulse in the last 10 seconds before the pulse check. We're going to go ahead and feel for a pulse in the femoral, in the groin area, right? We're going to feel for a pulse. It won't happen all the time, but most of the time you can feel a pulse there with compressions. Get your hand placement there, and then pause compressions. That's doing compression that's going to hover over the chest, about 6-7 inches above the chest. You're going to feel for a pulse. Your finger's already in the spot where the pulse will be. Your monitor is already charged. If you see VFib or VTAC and you don't feel a pulse, remove your hand, all clear. deliver the shock. If you see PEA, your finger's in the right spot, right? So you know that they don't have a pulse. You don't have to go digging around. And if they're in PE, continue compressions and dump the charge. And the same thing for asystole. You just dump the charge and continue compressions. And that's a 4-second pulse check.
Right.
That's what we found. And there's a couple of products out there. Physio has CodeStat. Zoll has another product for their monitors. But we started digging down into our cardiac arrests, analyzing them, and found that we have really, really long pauses.
You know, it's interesting because that's what I was going to ask you. What are you seeing from a clinical end of it when you review these calls?
Yeah, what we have found is typically, like I reviewed one yesterday, and there were 5 pauses over 10 seconds. And the longest pause was 1 minute and 6 seconds. And I could see what was happening, exactly what was happening. It was PEA on the monitor, and it looked like it was a really good PEA too. But end tidal was still 8, so low end tidal, so probably not perfusing. And I bet you they were sitting there looking at the monitor and be like, oh, this has got to be he's got to have a pulse, right? And so they're probably digging around, trying to find a pulse.
Hunting for it, yeah.
That looks too good not to be PEA, right? And so they're looking, and then they took them 1 minute and 6 seconds to figure it out that they did not have a pulse. Or it could have been, there's this other thing called pseudo-PEA. It could have been, but they could not feel a palpable pulse. And then they continued compressions 1 minute and 6 seconds later. And so that's what we're seeing is...
And that's what you're hoping for, right? It's a nice organized rhythm, right?
Yeah.
Impulses.
Yeah. But if you don't feel anything, a little bit of compression is not going to hurt them, right? If you're not confident that that is not a pulse, a few more compressions, 2 more minutes of compressions is not going to hurt that heart.
Yeah, and in bystander CPR, they don't even teach pulse checks anymore.
Unless the patient's moaning and moving, right? The Resuscitation Academy teaches this system. It starts at dispatch. There's this thing called no-go. One of the first questions the dispatcher will ask is the patient alert or is the patient conscious? If the answer to that question is no, then the next question should be, is the patient breathing? After they get their address, 2 questions should be, is the patient conscious? If that's a no, is the patient breathing? If that's a no, dispatch is a cardiac arrest. So we're getting immediate dispatch. It starts at dispatch with that, right? Then setting up your systems to where you have the availability with PD, good community outreach and getting citizens involved, doing the hands-only CPR, showing them that it's okay to do CPR, showing them the right way to do CPR. It's a whole system, and it's a big task to get everything set up.
Yeah, to get the population involved at that level.
Yeah.
So let's talk about this guy, Lucas.
Yeah, let's talk about him. I love Lucas. I do. I don't think that there's
a lot of resistance to wanting to take Lucas off the truck, or the Lucas device, I should say.
Well,
and there's memes out. I don't know if you've seen the memes.
I like it. Yeah.
Come and take it.
Let's talk about Lucas. I don't think there's anybody in this world that can do compressions as good as Lucas does. He doesn't get tired. He doesn't sweat. He get a cramp, right? So Lucas is great.
It's the risk, right? The time spent
setting it up. Depending on what your shop does, if you train with Lucas consistently and you're good and you can put that Lucas on, and there's different methods. There's 3 or 4 different techniques that you can efficiently put Lucas on. I think if you train with it,
you'd have to train
really well and really hard. I think if you train with it, like even if you do it once a week, just pull that thing out and put it on a dummy with your team, I think you can get it down to 10 seconds or under 10 seconds. But if we go back to what I said before about what are the 2 things that matter in cardiac arrest from an EMS standpoint, electricity and compressions, and minimizing those pauses. If we're taking 45 seconds, we've seen up to 2 minutes to put a Lucas on. If it's taking us 2 minutes to put a Lucas on, we're not doing anything for that patient. Right? So I think if you train with it and you can put it on, yeah, please. If you can get that thing on in 8 seconds, do it. Absolutely. Because it's going to save me from sweating if I can get that thing on. But if you don't train with it, I think the role of Lucas would be if you're transporting a cardiac arrest. So if you're not doing field termination, the patient doesn't meet criteria or your shop doesn't do it, then put them on right before you transport. It's important for us to remember that there's nothing that we can do that the hospital is going to do different. Right. And cardiac arrest is the main thing. Now, VFib, VTAC, refractory VFib or VTAC, there's a big thing with ECMO now, take them into an ECMO facility. But outside of that, working the patient in the house for as long as you can before you transport is the best bet, too. Because if you think about when we start moving patients, let's say we have them on the Lucas, right? We're moving them down a set of stairs. We got them on the backboard. We're moving downstairs. Lucas is over the abdomen doing compressions on their aorta, right?
So you didn't put the head strap on.
You didn't put the head strap on, right? Or it's shifted, right? Because, of
Yeah,
course
it
they're going to be,
happens.
it's going to be a split level house. You're going to be coming down. Somebody's hand is going to slip. It's going to turn the backboard a little bit. That Lucas may drift, may shift a little bit. We may miss a pulse check. We may miss an opportunity to shock the VFib or VTAC that we didn't see while we're moving. And so when we start moving patients, the care goes down a little bit until we get them to the truck.
Right.
And so really, at least for us, but at least for us, unless it's refractory VFib or VTAC, we're doing a lot of field termination if we're not getting ROSC or it's refractory VFib or VTAC.
So when VFib continues, how should the team approach the next stage of resuscitation?
This is going to depend on your local protocols, right? It's all dependent on your local protocol. It depends on your shop. Where we're at now, Stryker Physio Control does not support dual sequential defibrillation. So,
Talked about that the other day, right?
yeah. If you're doing it with a physio control monitor, it has the potential to void the warranty and the service contract. So they don't even work on it anymore.
Right.
Now, with that being said,
Describe what sequential defibrillation is.
yeah, so it's a hot topic the past couple of years, it's dual sequential. So your standard, where you put your pads, typically, you're going to put it over the apex of the heart, and then you're going to put one over there, like in the axilla, like over there, kind of your axillary. Typically, that's where we're putting the majority of our pads. Now, over time, depending on who puts them on, sometimes you have somebody putting them on a belly button. So first thing is you want to make sure we're putting them in the right spot. So just like the pictures on the pads, that's where you want to put them, exactly where the picture is. Now, the other way to put pads on is AP, right? Anterior, posterior. So what a dual sequential is, and there's two ways to do it. One is, so you have one monitor hooked up to the pads that you have your standard, right? The apex and the base of the heart. And then you have another monitor that's hooked up to the anterior, posterior pads. One way to do it is you'll do a countdown, charge your monitor to whatever the manufacturer suggests. So Stryker Physio Control is 200, 300, 360 on the LifePak 15. Charge your monitor to whatever dose, both of them at the same time, and then you'll do a countdown, 3, 2, 1, and then you'll hit shock at the same time. You're delivering 2 360 joule defibrillations. And basically, you're changing the vector, right? So you have one vectoring the standard way, apex to base, and the other one to go in AP front to back.
Right.
But it's doing it all at the same time. That's one way. The other way is one monitor will shock, and then about a second later, the other monitor will deliver the defibrillation. So one right after the other in sequence. So there's two ways to do it. And the data out there is mixed depending on what study you read. Sometimes that's how studies work, right? One study says it's a good thing. One study says it sucks, right?
Right.
But what I think, looking through the studies, talking to some physicians, talking to some folks up there at the Resuscitation Academy is what's the difference is changing the vector.
Right.
Is changing the vector from the apex base. So my suggestion is, just so you don't void any warranties or service agreements, contracts, change the vector, right? If it's not working, you've shocked them 3 or 4 or 5 times in the standard way, try the other way, right? And put some pads on AP, put one on the front, one on the back, and deliver the defibrillation that way and see if that works for you. Also, while you're doing that, consider, do you have any ECMO-capable EDs in your area, right? And see if, because those are patients that we do transport, right? We want to give them a chance. So see if we have an ECMO-capable ED in our area. There's a couple here in Atlanta that'll do it. So it's nice to...
How many shocks into this should you be considering changing the vector?
Probably 3 is what I would say.
Yeah.
I don't have any hard data off the top of my head, but I would say 3 to 4. Like if I'm...
It's not going to be detrimental.
It's not going to be detrimental. So if you're on your 3rd shock and they're still in VFib, yeah, go change it. You've delivered your 2nd defibrillation, maybe on your 3rd one. Hey, let's go ahead and put these pads AP, right? And so just give them...
Add in another set of pads.
But yeah, I love the cardiac arrest stuff, and because just in my mind, I think that that's where the 3 things where EMS really makes a difference is STEMI, stroke, cardiac arrest. That's where we make the biggest impact in patients' lives. You know, especially if you can get your cardiac arrest survival rate, VFib, VTAC survival rate up to 30, 40, 50%. I mean, that's huge for your community, and it's something that everybody should really work at.
Yeah.
Work on.
What organization is leading this effort in the country right now?
My training's been through the Resuscitation Academy. It's a nonprofit. They'll actually fly you out there for free on a grant. They have grants in your area through the CARES Foundation, and they will send you out there for 2 days. All the physicians come in, and then you can bring them back to your shop, and they give you all the materials for free, no cost.
What part of the country is this in?
Seattle.
Oh, it's beautiful there.
Yeah. We went earlier this year, and it was great because when we first started talking about this cardiac arrest stuff, one of the physicians that I work with was going on and on and on about it. And I'm like, all right. Every time he brought it up, I just kind of roll my eyes. Like, all right, we got other stuff we got to worry about. Like I'm not worried about cardiac arrest. We've been doing that for 20 years.
Is this part of Medic One in Seattle?
Yeah, so they're big into it. They're great. So I was talking to some guys up there. They're great. Like I've kind of.
It's such a different take.
It's such a different thing. It's awesome. And that's another place where you can tell that they're treated like professionals and they act professional, right? Like they walk around, they have these white coats on with their name tag. And it's, they treat themselves differently, but also, people kind of respect that name up there, the Medic One program. And they do cool stuff. Like I was talking to a guy for 45 minutes about cardiac arrest stuff, and he's just as passionate as I am, and he's on a truck.
Now, I've heard that if you're an experienced medic, you go to work for Medic One, you're pretty much going through their paramedic school all over again.
Yeah, they're going to teach you their way. Yeah. They will teach you their way. So it's great.
Let's talk about resilience versus toughness, the myths surrounding this, and how can EMS replace the just push through it mentality with a more healthier, sustainable definition?
I think EMS has kind of set itself up it's an industry issue. It's an industry problem. So if I go work for an EMS company,
right,
what are my pathways there to promote, right? I can become an FTO, right, maybe, become a supervisor, and that's about it, right? And just because I'm a good paramedic doesn't mean I'm a good supervisor.
Right.
And the industry's kind of...
Especially if you just want to get off the truck.
So the industry's handicapped itself, puts you on this path. That's all you can do, right? If I want to stay at one company and I want to promote, and I'm going to be a FTO, then I may be a supervisor, and that's about it, right? Then what do?
Maybe clinical education or something.
Right. But like in my shop, it's one clinical educator for 350 employees, right? Not a lot of people are going to get that opportunity.
Right.
It's not exactly an easily promotable position. What I'm trying to do is make another pathway, right? So I want to make a pathway to where you can be and go up like a clinician arm, right? That'll kind of lead to an educator or a clinical specialist. So really it's finding interested paramedics who love their job, who don't want to get off a truck, and finding a way to promote them clinically. And what we've done is we've created a QRV program where they have a little bit more of an expanded skill set, right? So they carry blood, they have better equipment, different equipment. We're about to carry a different video laryngoscope, a newer, nicer one.
What are you looking at?
GlideScope Go.
Oh.
Yeah. It's either that or the one scope, but I may go with the GlideScope Go. I don't know. I like all of them. I think as long as it has a video and it's something that you don't have to change your technique, that's the way to go for the video loads.
People that have been using, conventional laryngoscopes.
And I think, because there's some products out there where you had to change your technique completely. So everything I've been doing for 16 years, I'm going to have to change to use this video laryngoscope. And so you have to kind of retrain. If it's a product like that, nah. But if it's just a Mac 3 or a Mac 4 with a video camera on the end of it, I think those work great. As long as it has a little bit of a screen that you can see.
Yeah, I've used both. I didn't find it too much of a learning curve to switch to it.
Yeah.
I think you can drop down, visualize.
There's some products that you can't. You have to feed the tube through a channel, and then you have to hold it with like 2 or 3 fingers. It could be a challenge. But whatever works best for you. Everybody has a different preference. You got to find the one that works best for you. And when we were doing this, we trialed 3 or 4 different products, and we found the one that we like. Everybody came in. It's not Sam making the decision. We came together as a group and, hey, what are the likes and dislikes when we buy a product like that? What I've done is create this clinical pathway to where they don't have white jackets, but they have a red shirt. So they're set apart a little bit different. There's a vetting process that they have to go through, right? So we go back 6 months and look at their documentation. We put them through an interview process. There's a very challenging clinical scenario, a very stressful, challenging scenario that you have to critically think through because it's going to be a patient that doesn't fit your guidelines, right? You're going to have to think outside the box. We put them through a class, like a training and education, and we score them on each of those things, and then we pick the ones that have the top scores. I have an opening for 5 now, and so we'll pick the 5 highest scoring ones to do it. So it's a process, and I think that process makes it more valuable. And then people look at you, and they're like, oh, they were through that hell of a scenario. So, yeah, it's nice. And then with them, we give them a lot more education. Of course, we open the education up to everyone, but we require them to complete a lot more education. And so what we developed is if one of those medics, these QRV medics, shows up on the scene, you know that you're going to have a competent medic that not only is strong clinically, but they have leadership skills. They're able to manage a scene, right? A scene shouldn't be chaos. It should be a choreography. They're able to choreograph these scenes. A byproduct of this is they hold themselves accountable. Like, you don't have to tell them anything. They manage themselves because they want to keep this role and want to keep this spot. Where if they don't call out, their documentation is impeccable. Their trucks are clean inside and out. Nobody asked them to do any of this. They do it because they respect the position and they respect the job.
Right.
It's kind of a micro thing of what happened in aviation. My experience in the aviation is going to happen here. I didn't really do anything other than set up these difficult scenarios and interviews.
Right.
But yeah, they hold themselves to a higher level than the rest of the crews, and it's interesting to see.
Do you think this will help with burnout and retention?
I think a little bit. I think if you are a high performer and you love the job, I think it'll help, right?
Yeah.
Because it kind of gives you another pathway. But I think if EMS is just a job for you, I don't think it'll do anything, right? Because it's just a job. But if EMS is your passion and this is your career, like this is something you want to do, like we've had great success with making a couple of adjustments and then adding this kind of wing. And then we have 2 trucks up per shift. They go out, they pick and choose what calls they want to go to. The only calls that they're required to go on are high acuity trauma calls, shooting, stabbings, vehicle accident with entrapment.
Right.
Those are the calls that they're going to be dispatched to, but everything else they pick up, right? So they're picking up the cardiac arrests. They're picking up nursing home calls, right? They carry IV pumps, which our typical trucks don't. But
Labs.
But they'll go out there because a lot of nursing homes, a lot of sepsis out there.
Right.
And so they have this, it's just interesting to see how that program has taken a life of its own, and you don't really have to manage it, which is nice because they manage themselves. I just give them the tools that they need to succeed, and they take it and run. And the whole group's done great.
Why do you think paramedics are leaving the profession or not getting into it? Because there is kind of a deficit in paramedics nationwide, right?
And I think that's kind of been the whole, I don't think EMS is public safety. I hate grouping EMS into public safety. But if you look across public safety, fire, EMS, PD, you see that around. And I don't know why people aren't interested in it anymore. It's not money, right? You can come here and make a great living. Paramedic, from EMT to paramedic, you have a year and a half of school, and you can come in to pretty much anywhere in Metro Atlanta and make 6 figures with just a little bit of overtime. You can make a very good living as a paramedic in Metro Atlanta. I don't know why people aren't interested in this career anymore. I've seen it drop off even in my 15, 16, 17, however many years I've been in. I've seen it drop off, like just the interest in it. I don't know the answer to that. I like to think it's maybe the lack
If you had the answer, you could make a lot of money,
I can make a lot of money, yeah. But, yeah, I think we did a good job. We don't do a very good job of promoting the career, right? I mean, if you look at people in the 70s and 80s, right, they had an emergency on the TV, right? Watching that, and everybody was like, yeah, I watched Emergency. I want to get into this, right? Your generation. No, I'm just kidding.
Ooh, it stung a little.
No, but us, our friends' generation down there. But now there's not anything. How do people even know about their career?
I think if you look at the ladder of public safety, and
Sure.
and I don't think we really fit on that ladder much, but if we do, we're on the bottom rung.
I agree.
And if you're in private EMS, you're holding on to the legs of the guy on the bottom rung.
Because if you look at fire department, right, how many different jobs are there in the fire department, right? You can go work on an engine, then you can go work on a ladder, you can go work on a heavy rescue unit, some sort of squad. I'm going to go work for fire marshal's office, or I'm going to go work in training, or I'm going to do that. There's tons of things you can do in the fire, many pathways. Police department, same thing. I can go work streets. I can work gangs unit, narcotics. I can be a detective, there's so many things that you can do in those two, rungs of the ladder, right?
Right.
EMS, you work a truck.
Yeah. Even in nursing, right? So many different specialties.
Nursing, same thing. Metro Atlanta pay is comparable to new grad nursing pay. There's not that big pay difference. For years, nurses are making so much more than us medics.
Right.
But nursing has a better working environment, right? You're in the air conditioning, right? And you're walking around passing meds, whatever. There's a lot more to that job than passing meds, by the way. It's just,
I know.
From a paramedic perspective, right? That's what that's what we're going to say. But they can do whatever, right? There's even jobs at home for them. They can go work for a health insurance company, Blue Cross Blue Shield, and sit on their couch and look at charts all day.
Yeah.
For paramedics, if you're not on a truck or working as a tech in the hospital, then you're not really. What are you going to do?
Yeah.
So
my wife works in IT for a very large company that does hospital-based software.
Yeah.
And she specializes in pharmacy modules, our modules, and they're always hiring nurses.
Yeah.
They'll teach them the IT side.
Yeah.
Yeah.
Yeah, that's cool. And there's not a lot of that for EMS.
Yeah. And she's going to be in Seattle next week at a couple of hospitals out there.
That's cool.
What do new paramedics need to learn that they can't fully be taught in the classroom or by a textbook?
It's okay not to know everything. It's okay, right? I think if you come out and you realize that the base level of education that you have, that's just the floor. That's just the bare minimum to be on an ambulance. I think if you come out with an open mind and you're hungry and you want to learn, you're going to have the best career from day one. If you come out and you want to learn and you want to help people and you're nice, you're going to...
It really is a big thing.
I mean, if you come out and you're hungry and you're in this for the right reasons, then you're going to have a great career. And honestly, it does not take much to excel in this career, right? Just knowing that it's okay not to know, but be hungry for knowledge and just care. And that's it. That's really all it takes to be a good paramedic, good EMT.
Yeah, if you get into it to earn money sleeping, you'd be disappointed. You're not going to get much sleep. And
not anymore.
Yeah.
Yeah, I mean, EMS, I love it. I don't know what I would do if I couldn't work in EMS anymore. I don't have any other skills, so I don't know what I would do. I think if I was a young paramedic, just be hungry for knowledge. It's okay not to know, but know where to go if you have a question. And that's where good leaders and good supervisors come into play, having that open door, being that person where people feel comfortable coming to you with an issue or a problem and help them solve it, build them up.
Yeah, I agree.
Yeah.
Yeah. This has been great.
Yeah.
Love doing it.
Yeah.
You're doing a great job. People can find you, right? If they want to look you up, they can get you on LinkedIn.
Yeah, I'm on LinkedIn. I don't have Instagram or anything. But
who has time for it?
Find me on LinkedIn. If you need help, cardiac arrest stuff, I'm pretty good with data management. If you need help starting a cardiac arrest program and looking at your numbers and how to look at your survivability of cardiac arrest, let me know. We didn't talk about it much, but started the blood program here. There's different types, but if anybody needs any help with either of those two things.
We didn't even get into that.
Well, the problem is everybody's talking about blood.
I've done a few episodes. It's pretty, actually, it is pretty amazing thing to have that ability.
Yeah.
That skill or tool on your truck.
Yeah.
When needed, makes a huge difference.
Yeah, it does. We're seeing good success with it. The biggest thing for me is empowering paramedics, and carrying something like that. It's something that's precious and perishable. Really empowers paramedics because we can do it. And seeing the gleam in their eye when they have a successful trauma and they give it, it's great. So it's nice to empower those paramedics.
Yeah.
Yeah.
And you have whole blood, right? We're not doing component therapy.
They just came out with a SWIFT trial. There's a study called the SWIFT trial, and basically it compared whole blood to components, and there's no difference between the two. So if you want to carry components, carry components. Whole blood, a little bit more difficult to manage. You can do more with components, especially now with head injuries and sepsis and plasma. Peter Antevy says that if he could go back in time, he would have started with components instead of whole blood, because you can do a lot more with components than you can with whole blood.
Wow.
So it just depends on your system. And sometimes if you're in a rural community, maybe all you need is some plasma, right? And that's okay too, right? That's still going to expand their volume and it's still going to help, right? It has the clotting factors in there and trauma and GI bleeds that can help with that. So even if you're just a rural 2-ambulance service, it's cheap and it's easy to get, and you can carry it and you can give it, and it's actually going to help somebody. So,
it's got a longer shelf life, doesn't it?
Yeah, and it's cheap, right? Typically the blood banks won't take plasma back, but that's okay, right? Because it's $30, $40, whatever it is. And then you can toss it and go to the next one.
Right.
So,
And it really is the logistical end of it, right? To manage it.
yeah.
The burden is more on that end than on the provider.
The managing of the system can be a challenge. There's different ways. Easiest way is to find a hospital to hook up with and have them provide your blood. If they can't, then find a blood bank. That's what we did. We partnered with a blood bank and we purchased our blood from them. Our challenge is they don't exchange. If we don't use it, we lose it. So managing that system, managing your inventory is a whole nother thing.
Yeah. In the communities, you're using it in those communities.
Yeah, we have less than a year, we've used 130 units.
Wow.
Yeah, we're using a good bit of it.
That's awesome.
Yeah.
Hey, thank you so much.
Thank you for having me, man.
Maybe we'll get you out here again to do this.
I'm excited.
You
I love
bet.
it. Thank you
Thanks.
so much. You may be the newest face that person's ever seen. What am I trying to say, Jason?
I don't know.
Thank you for listening to In Service, the EMS podcast, where frontline experience meets leadership insight. If you have found value in this conversation, please like, subscribe, share, and leave a comment. You will find links in the episode notes.